lecture is about carbonic anhydrase inhibitors acting as diuretics and osmotic diuretics. So here we will discuss the mechanism of action, the clinical uses and adverse effects of these drugs. About carbonic anhydrase inhibitors, the mechanism of action, pharmacological effects, clinical uses and adverse effects of carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors inhibit the carbonic anhydrase enzyme that is present primarily in the kidney, but they are also present in the central nervous system, the eye, gastric mucosa, pancreas and red blood cells. What led to the development of carbonic anhydrase inhibitors? When sulfanilamide was introduced initially as a chemotherapeutic agent, it was recognized that metabolic acidosis is a side effect. Digging deeper into the underlying reason for metabolic acidosis, it turned out that sulfanilamide is a carbonic anhydrase inhibitor. Subsequently, enormous number of sulfonamides were synthesized and tested for the ability to inhibit carbonic anhydrase enzyme. Acetazolamide is most extensively studied carbonic anhydrase inhibitors. The three orally administered carbonic anhydrase inhibitors are acetazolamide, betazolamide and dichlorphenamide. Dorzolamide and brinzolamide are topical preparations of carbonic anhydrase inhibitors and are used in the eye. So let's see how do the carbonic anhydrase inhibitors act on the kidney and what are the effects on electrolyte excretion in urine. As we can see in this figure, the action of carbonic anhydrase inhibitors is on the proximal tubular epithelial cell. The carbonic anhydrase enzyme is present in the cytoplasm of the cell, in the luminal membrane and also in the basolateral membrane. As we can see, carbon dioxide combines with water to form carbonic acid or H2CO3 in presence of carbonic anhydrase enzyme. The carbonic acid dissociates to form H+ ions and bicarbonate ions, which is reabsorbed into the interstitium with the help of a symporter that transports sodium and bicarbonate into the interstitium. In the basolateral membrane, the sodium-potassium ATPase pump functions at the basolateral membrane and creates an electrochemical gradient which is utilized by the antiporter that transports H+ ions into the tubular lumen. So hydrogen ions are secreted into the tubular lumen, which combines with bicarbonate ions that are filtered through the glomerulus into the tubules and forms H2CO3 or carbonic acid. H2CO3 in presence of carbonic anhydrase enzyme dissociates into water and carbon dioxide, and carbon dioxide being lipophilic is absorbed into the tubular epithelial cell and combines with water to form H2CO3 and the process continues. So what are the effects of carbonic anhydrase inhibitors on electrolyte excretion in urine? Carbonic anhydrase inhibitors, by inhibiting carbonic anhydrase enzyme, inhibit the reabsorption of bicarbonate into the interstitium and cause increased excretion of bicarbonate in urine, which combines with sodium, and sodium bicarbonate is lost in urine. So there is loss of sodium and bicarbonate ions in urine. Also, the action of carbonic anhydrase inhibitors on the collecting duct inhibits the secretion of acid. So this induces metabolic acidosis and causes hyperchloremic metabolic acidosis. Thus, hyperchloremic metabolic acidosis occurs because of increased excretion of bicarbonate in urine and inhibition of excretion of acid into the tubular lumen. So what is the effect on potassium excretion in urine? The inhibition of sodium reabsorption in the proximal tubule causes increased delivery of sodium to the distal tubule, and this causes increased secretion of potassium into the tubular lumen. Due to increased secretion of potassium in urine, there is increased secretion of potassium in urine, and hypokalemia can occur as a side effect of carbonic anhydrase inhibitors. Also, it has been observed that phosphate excretion is enhanced in urine, but there is no effect on calcium and magnesium excretion, unlike loop diuretics that influence calcium and magnesium excretion in urine. So to sum up, the electrolyte excretion in urine, the anions that are excreted in urine are bicarbonate ions, chloride ions and phosphate ions. The cations that are excreted in urine are sodium, potassium, but there is no effect on excretion of calcium and magnesium. Next, what is the effect of carbonic anhydrase inhibitors on urinary pH? Due to the action of carbonic anhydrase inhibitors on the collecting duct, there is increased excretion of ammonium in urine. This causes a rise in pH of urine and causes alkalization of urine, which occurs because of carbonic anhydrase inhibitors. Amongst the side effects that we have discussed, hypochloremic metabolic acidosis and hypokalemia can occur as side effects of carbonic anhydrase inhibitors. What are the other actions of carbonic anhydrase inhibitors on extrarenal tissues such as eye, the central nervous system, gastric mucosa and the erythrocytes? In the eye, carbonic anhydrase enzyme is present in the ciliary process that mediate formation of bicarbonate ions. So inhibition of carbonic anhydrase enzyme decreases the bicarbonate formation and this decreases the production of aqueous humor, thus lowering the intraocular pressure. This helps in reducing the intraocular pressure in glaucoma and therefore carbonic anhydrase inhibitors are useful for the treatment of wide-angle glaucoma, acute congestive glaucoma and secondary glaucoma. On the central nervous system, carbonic anhydrase inhibitors have direct action and they also induce metabolic acidosis. This raises the seizure threshold and therefore carbonic anhydrase inhibitors have mild anticonvulsant action. In the gastric mucosa, carbonic anhydrase enzyme is responsible for the formation of gastric juice. So, the inhibitors of carbonic anhydrase enzyme can cause decrease in the gastric acid production. In the red blood cells or erythrocytes, interference with the carbonic anhydrase enzyme causes increased production of carbon dioxide in the peripheral tissues and decreases the partial pressure of carbon dioxide in the expired gas. Therefore, this can induce metabolic acidosis and respiratory acidosis. Coming to the clinical uses of carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors are useful for the treatment of open-angle glaucoma, acute congestive glaucoma and secondary glaucoma, which is characterized by raised intraocular pressure. Acetazolamide that is administered orally in the management of glaucoma can cause side effects such as metabolic acidosis and hypokalemia. Topical preparations such as brinzolamide and dorzolamide cause less systemic side effects and are better tolerated. They cause no diuretic response and they have more selective action on the eye and they are preferred in the management of glaucoma compared to acetazolamide, which is orally administered and which causes systemic side effects such as metabolic acidosis and hypokalemia. The second clinical use is urinary alkalization to treat urate calculus. In clinical conditions such as leukemia and lymphoma, when chemotherapy is administered, there is increased metabolism of nucleoproteins causing increased production of uric acid or hyperuricemia. Because of increased production of uric acid, there is precipitation of urate calculus in urine in the tubular lumen. Carbonic anhydrase inhibitors helps to make urine alkaline and causes solubilization of the urate calculus. Therefore, carbonic anhydrase inhibitors helps to make urine alkaline and treats urate calculus. The third use is metabolic alkalosis. As we have learned that carbonic anhydrase inhibitors induce metabolic acidosis, they can be used for the treatment of metabolic alkalosis. Next, carbonic anhydrase inhibitors are used as adjuvant and short-term treatment of petit mal epilepsy or absence seizures because of its anticonvulsant action. The anticonvulsant action is due to direct action on the central nervous system and because it induces metabolic acidosis. So this can raise seizure threshold and decreases the incidence of convulsions. Next, the use of carbonic anhydrase inhibitors in acute mountain sickness. When the mountaineers ascend rapidly above 10,000 kilometers, they can experience headache, dizziness, weakness, and can also experience pulmonary edema and cerebral edema. This is because of hypoxia at high altitude. This causes hyperventilation and carbon dioxide is washed off from the body, and this causes respiratory alkalosis. Carbonic anhydrase inhibitors induce metabolic acidosis and can counteract respiratory alkalosis that is caused because of high altitude and because of hypoxia. Therefore, carbonic anhydrase inhibitors can be useful for the treatment of acute mountain sickness. Speaking of the adverse effects, carbonic anhydrase inhibitors are sulfonamide derivatives. Therefore, they can cause hypersensitivity reactions. Finally, we have learned that these drugs cause increased excretion of ammonium in urine. So, the ammonium that is excreted in urine is diverted from the urine into the systemic circulation, and this can induce hepatic encephalopathy in liver cirrhosis. Therefore, these drugs are contraindicated in liver cirrhosis. Thirdly, because carbonic anhydrase inhibitors cause alkalization of urine, they cause precipitation of calcium phosphate salts. And lastly, there can be worsening of metabolic acidosis because the carbonic anhydrase inhibitors induce metabolic acidosis, and therefore they are contraindicated in COPD or chronic obstructive pulmonary disease, where there is respiratory acidosis and metabolic acidosis. Also, it is to be kept in mind that long-term use of carbonic anhydrase inhibitors decrease the efficacy or leads to the development of tolerance, because these drugs can induce metabolic acidosis, and over a period of days there is increased reabsorption of electrolytes, that is sodium and bicarbonate, by the tubules, so the diuretic response decreases. So the diuretic response becomes self-limiting. Thus, the diuretic response becomes self-limiting because the carbonic anhydrase inhibitors are used over a period of days, and this leads to the development of tolerance. Next, we move on to osmotic diuretics. Osmosis is the movement of solvent from the region of low solute concentration to the region of higher solute concentration through a semi-permeable membrane. Clinical example of osmotic diuresis is polyuria in diabetes mellitus. In diabetes mellitus, there is hyperglycemia causing glycosuria. There is increased filtered load of glucose in urine, which exceeds the reabsorptive capacity of the tubules. So this retains or extracts water through the tubular membrane and causes water diuresis, increases the voidable urine. The drugs that are used as osmotic diuretics can be used intravenously, for example, mannitol and urea, and the drugs that are used orally are glycerin and isosorbide. So how do the osmotic diuretics act? The site of action of osmotic diuretics is the proximal tubule and the descending limb of loop of Henle that are freely permeable to water. Some of the characteristic features of osmotic diuretics are they are pharmacologically inert substances and are readily filtered through the glomerulus but are not reabsorbed through the tubules. The presence of these substances in the tubular lumen increases the osmotic pressure, and increased osmotic pressure causes extraction of water or removal of water from the body through the tubules into the lumen. So this helps to retain water in the tubular lumen and increases the water diuresis. Increased osmotic pressure in the tubule antagonizes the action of vasopressin or antidiuretic hormone, becomes less effective, and this further increases the diuretic response, increasing the water diuresis. Coming to the therapeutic uses of osmotic diuretics. These diuretics are used to prevent acute renal failure. In clinical situations such as shock or crush injury, there is oliguria and onset of acute renal failure. So this decreases the urine flow as a compensatory mechanism. The proximal tubule reabsorbs sodium chloride water and the distal parts of the nephrons are dried up, and this leads to renal failure. Osmotic diuretics increase the osmotic pressure in the tubular lumen, draws out water through the tubules, helps to retain water in the tubular lumen, and increases the voidable urine and prevents renal failure. Secondly, these diuretics can be used for the treatment of glaucoma and cerebral edema. When administered intravenously, they increase the plasma osmolarity, and this draws water from the eye, from the aqueous humor of the eye, thus decreasing the intraocular pressure in glaucoma. Therefore, they are used to treat glaucoma, and also they can be used in the treatment of cerebral edema, as increased osmotic pressure draws water from the brain parenchyma, decreasing the intracranial tension and cerebral edema. Hence, osmotic diuretics find use in the management of glaucoma and cerebral edema. Thirdly, these drugs can be used to remove toxins from the GI tract. Osmotic diuretics, when administered orally, causes osmotic diarrhea and helps to remove toxic substances from the GI tract. These diuretics can be used to treat hypotension in barbiturate poisoning. Lastly, osmotic diuretics can be used during dialysis, radiodiagnostic procedures, and during surgery. It has been observed that rapid hemodialysis can cause hypotension due to removal of extracellular fluid. This can cause headache, nausea, vomiting, dizziness. So to prevent these symptoms and to prevent hypotension, osmotic diuretics are used, and this can cause expansion of extracellular fluid volume and prevent hypotension in dialysis. Also, these diuretics can help to maintain the renal blood flow during radiodiagnostic procedures and in surgeries that are performed prophylactically in jaundice patients and in other surgeries such as vascular surgeries or open heart surgeries. So these diuretics help to maintain renal blood flow. Therefore, these diuretics help to increase and improve the renal blood flow.
This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.